Yeah.
Good afternoon, everyone. My name is Brian Castrucci, and I will be your host for today's webinar on how perceptions of public health have changed during COVID. Before we get into our speakers, just want to give you some background on why we are here today. Clearly, public health has added 25 years to our life expectancy, and everyone on this webinar knows the importance of public health. But if you listen to media reports, you would believe that there is a war happening around public health, that not everyone believes public health as they should. We have anti-maskers and COVID deniers. And the question is that really the mainstream belief, or is that a small vocal minority? And we'll answer that question today. We will also look at how we better make partnerships in or with other folks in the community using framing and messaging. I think we all recognize that somewhere during this pandemic, a health department leader met with a school superintendent. They said hi because it was their first meeting, and then we told them they had to shut down their schools. And that's probably not the best first date you could ever have. And so we need to really build our partnerships such that people recognize and realize that public health is here to support the best community outcomes we can have. And I think we will hear today and leave this webinar with some amazingly good tips and tools that you can immediately apply to your own practice. So it is my privilege to introduce our two speakers. You will be hearing from Elizabeth Harrington. Elizabeth is a partner at Public Opinion Strategies. Since joining the firm in 1998, the major focus of Elizabeth's work has been public affairs and public policy research, managing over $25 million of both qualitative and quantitative research projects. During Elizabeth's tenure at Public Opinion Strategies, she has been promoted from project director to senior project director to vice president to partner. Her research background has focused primarily on topics such as healthcare, Medicare and Medicaid reform, hospitals, media tracking, message and advertising testing, public education campaigns, and corporate image testing. Elizabeth's research experience on key health policy issues has included work for America's health insurance plans, the American Medical Association, the Centers for Disease Control and Prevention, some other foundation, Robert Wood Johnson or something, I'm not sure who they are, and of course, the pinnacle of her career, working with the Beaumont Foundation. Prior to joining Public Opinion Strategies, Elizabeth worked for 3 years as the market research director for a research and publishing company. She currently resides in Philadelphia, showing that good things come out of Philadelphia. So thank you, Elizabeth, for joining us. We will also hear from Nat Kendall Taylor. Nat is the CEO at Frameworks Institute. He oversees the organization's pioneering research-based approach to strategic communications, which uses methods from the social and behavioral sciences to measure how people understand complex socio-political issues and tests. As CEO, he leads a multidisciplinary team of social scientists and communications practitioners who investigate ways to apply innovative framing research methods to social issues and to train nonprofit organizations to put the findings into practice. So, I've had the pleasure of working with Nat for some time. If you've not kind of seen the presentation on framing, it's going to blow your mind. And so we have some truth to tell today. And without further ado, I want to move this over to Elizabeth so we have enough time for questions at the end. Take it away, Elizabeth.
Thank you, Brian. You can go ahead and change to the next slide. And the next slide. Hi, this is Elizabeth Harrington from Public Opinion Strategies. As Brian mentioned, we conducted a national telephone survey among registered voters in July on behalf of the Beaumont Foundation. This is a track of some core key questions that we had conducted in a poll on public health, a national poll that we had conducted also in 2018. And so this is a look 2 years later at where attitudes are on public health. You can go ahead and change to the next slide. Before we get to the findings of this poll that we did for the Beaumont Foundation, this slide we have in here is just to show you some perspective in terms of where attitudes are among the public about what are the most important issues facing the country. This is from work that my firm has released in August. It was a track that we had done for Gerard, another communications firm, in April. And as you can see, in terms of the top issue facing the country and what voters are most concerned about, it's still the coronavirus, and by large margins. Even when we're in a political cycle and there are other issues on the table, the coronavirus is still the main, most important issue that people are focused on. You can go ahead and turn to the next slide. So moving on and looking at the Beaumont poll that we did in 2020, as I said, this is a track from 2018. So we're looking at how attitudes have shifted on public health. The coronavirus is clearly having an impact on how voters' perceptions are about those healthy communities and the importance of public health departments. You'll see when we get into the detailed charts and the analysis that public health departments are viewed as having a more important role today in creating healthy communities than they did 2 years ago. In addition, there's an increased importance on preventing the spread of disease. But it's important that that hasn't taken away from support for other services that public health departments offer. And voters continue to value all of the services that public health departments offer. In this research will also show you that a majority of voters still say they would be willing to pay more in state and local taxes to increase funding for local public health departments. That's risen slightly, but just above the margin of error since 2018. And familiarity with public health departments is up since 2018, where people are saying they're more familiar with their local public health department. But what's important, I think, as we get into what Nat's going to talk about and some of the communications that public health departments should be doing, there wasn't very much movement on the very familiar percentage, which means that there is still room to grow and for public education on what public health departments do and the services that they provide in communities. You can go ahead and move on to the next slide and the next slide. So one of the things that we did in the survey and that we tracked from September 2018 to July 2020 is we had voters rate the importance of public health departments in creating a healthy community. We use a scale of 1 to 10, where 1 means not at all important in creating a healthy community and 10 means very important. You can see from the data from 2018 to 2020 Today, more than 7 in 10 voters now say that public health departments are important in creating a healthy community, and the very important percentage rose from 27% to 42%. So these are large jumps, and as I mentioned, it's clearly due to the time in which we did the poll, and obviously that we're in a public health pandemic. You can turn to the next slide. So there's a lot of data on this slide, so I'm going to highlight it and kind of the key points. What we looked at from 2018 to 2020 is the percentage of voters who rate the importance of public health departments high in creating a healthy community, meaning it's very important. On the left-hand side is looking at the percent rating at a 10 on that 1 to 10 scale. On the right is looking at the percent who rated an 8 to 10. And you can see if we look at those that are rating at a percent 8 to 10, we have the all voters percent, which was a plus 17-point rise, but you can see kind of some of the key audiences where the importance has significantly risen from 2018 to 2020 are white men, men college plus, Republican men, strong Republicans, whereas in 2018, they did not see the value or importance of public health departments. Today, majorities of those audience and significant majorities are saying that public health departments are very important in creating a healthy community. You can go ahead and turn to the next slide. So these next few slides are going to be looking at the percent 10 in dark blue, the percent 8 to 10 is the total. And this is, again, the rating of importance and showing you the rise in the importance ratings. So across party and across ideology, the importance and value that public health departments have in creating a healthy community has risen sharply from 2018 to 2020. You can turn to the next slide. And this is true across socioeconomic status as well. You can see there are differences when we're looking at how people classify themselves. That's the poor, working class, middle class, upper class, well-to-do. We have them self-report how they would qualify their economic circumstances rather than looking at income in terms of how they feel they are economically off. And you can see that the importance of public health departments is a bit higher among those in middle to lower income households. You can turn to the next slide. And again, we just want to show across gender, age, ethnicity, the significant rises that you see in the value really across all voter groups in terms of how important they believe public health departments are in creating healthy communities. African American, Hispanic, non-white groups always, in our past research in 2018, had rated the value as very important. You can see they were at 76 in 2018, they're at 79 now, but this growth is really coming from all voter subgroups and audiences. You can go ahead and turn to the next slide. And this slide is showing again what are the groups that really value public health departments the most. And so we're looking at the people who rate public health departments the highest in terms of their importance in creating a healthy community. And it's African Americans, Hispanics, women, those in lower socioeconomic households, and those living in urban areas, younger voters, and Democrats. You can go ahead and turn to the next slide. So this goes to the point that I mentioned earlier, where I don't know what just happened with the slides. Okay, so they're back up. This goes to the point that I mentioned earlier, where how familiar people are with their local public health departments. We asked a question and asked them to say whether they were very familiar, somewhat familiar, not too familiar, or not at all familiar. You can see the rise in familiarity due to the situation that we're in today. But what the point I think that's very important to make here is if you look at the intensity and you look at those that say they're very familiar, in 2018, that was 15%. In 2020, that's 17%. So there hasn't really been much of a shift in terms of how familiar people are with the services that public health departments provide and how familiar they really are with them. But obviously with their local public health departments in the news during the pandemic, the overall familiarity has risen significantly since 2018. You can go ahead and turn to the next slide. And those groups that report being most familiar with public health departments are consistent with those groups that I mentioned before who value public health departments the most in terms of African Americans, non-whites, urban residents, women, Hispanics, Democrats. And so you can see that there's a theme here in terms of people who are familiar with the departments most value the departments as well. You can turn to the next slide. We tested, and you'll see this in a bit in the next few slides, but we tested a series of services that public health departments offer in communities. And after hearing the list of services that public health departments offer, we asked voters whether they would be willing to pay more in state and local taxes each year in order to increase funding to ensure that every community in their state, so we inserted their own state, receives all of the public health services from their local public health department. You can see that the percentage of people who are willing to pay more in state and local taxes annually has increased slightly above the margin of error, but that we now have, we still have a majority, 6 in 10, who say they're willing to pay more in taxes to make sure the local public health department services are available to everybody. You can move to the next slide. And the next slide. So we've divided this up across some different slides, but these are looking at all of the different services that we tested and asked people about in terms of things that their local public health department could do in their community. And for each item, we had them individually rate how important it was to them personally that their local public health department provided that service in their community. So we have 11 public health department services that we tested. All 11 of them are viewed by voters as being important for public health departments to do in the community. If we're looking at both the percent, if we're looking at the percent 8 to 10, you have majority saying all 11 are important. And the most important service, not surprisingly, given the pandemic that we're in and the coronavirus, that the most important service continues to be helping stop the spread of communicable diseases in communities. We did split sample that question here in our track in 2018. We had not mentioned the coronavirus. Obviously, and given the situation today, we mentioned the coronavirus. There is a little bit of a difference in intensity when you look at the percent 10 who are rating the importance of that service. But overall, the top service from 2018 to 2020 is helping stop the spread of communicable diseases. You can go ahead and turn to the next slide. So this is looking at those services that we tested in 2018 and 2020 in terms of the movement and shift in the percent 10 rating. So importantly, none of the public health services dropped in their level of importance since 2018. And these are the items that received higher importance ratings in 2020 than they did in 2018. Importantly, providing critical unbiased information on how to respond and what to do in a crisis, working together with the broader healthcare system to address problems before they become health crises, reaching out to people that are at greater risk of having poor health outcomes, and working to improve local community services, supporting women and children's health, and establishing prevention programs. You can turn to the next slide. So these are the services where the ratings were consistent from 2018 to 2020 within the margin of error, that we didn't really see much movement in terms of ratings, in terms of importance. You can turn to the next slide. Right now I'm going to shift it over to Nat, who's going to talk about, as Brian mentioned, the phrases research and some of the work that Framework has done.
All right, Elizabeth, I can still see you. Can you hear me? Give me a thumbs up. Yep, great, and you can see my slides just to make sure. Great, thank you so much. Thank you for all of you for being on. And I hope you're doing okay today and hanging in there. I am super excited to be here with you all, and even more super excited to get the next 25 minutes to talk to you about framing, which is, as Brian can attest, my all-time most favorite thing to do, which is decidedly sad and pathetic, but also means that for the next 25 minutes, there is guaranteed to be one person on this webinar who's having fun. That will be me. I will have fun talking about framing. I make no other promises. And I resent the high bar that Brian set when he said I would blow your mind. That's dangerously aspirational. And again, I'm not making any promises on that front. I want to thank Brian and Beaumont for inviting me to be here today, but also for their partnership along with the Aspen Institute in the research that I'm about to talk about. And no offense, Brian, but even more importantly than thanking you is thanking everyone who is spending this time on this webinar. I realize your time is incredibly valuable. It's always been valuable. It's like even more valuable now. In exchange for that time, I'm gonna try to add some value to your work and be helpful in some way. It's important to say at the outset that I am not someone who's trained in public health. I'm not in the public health field. I'm an anthropologist by training. I do a kind of anthropology that's called psychological anthropology, which means that I am deeply fascinated, fixated on the way that culture influences how people think, how people use culture to process information, to make meaning of messages, and to formulate and reach decisions. And so that really is, I'm not just telling you that because I think you think it's important, but that kind of premise, the way that culture in our minds influence how we think and how we feel and what we do, is really the core of what I'm going to be talking about today. So the guiding question in this project that I'm going to be talking with you about today is the idea of, what are the ways that the field of public health can communicate about its worth, about its work, about its worth, to increase the perception of the value of that work and the willingness of other sectors to collaborate. And just so you have a sense of what I mean when I say other sectors, the work that was part of this project was kind of looking specifically at the education sector, at the healthcare sector, at the housing sector, and at the business sector. And so as we begin delving deeply into a presentation on framing, I think it's really important at the outset that we provide some common definition of what we mean when we say framing. So framing is one of these words that I regret to say has become so utterly ubiquitous that I fear it has lost any and all meaning it ever once had. So as an antidote to that, as a remedy, we're going to get together on a definition of what this word means. So when we talk about framing, again, for the next 25 minutes, what we mean is how the choices that we all make, we all, like everybody, makes in how we present information. And sometimes those are like really clear, obvious choices, the values that we use to argue for why an issue is so important and solutions are so paramount. But it's also the seemingly nuanced and maybe insignificant choices that we make. Do we use the pronouns of us and them, or do we talk about we, right? Do we use verbs that imply and extend agency to groups of people? Or do we choose verbs that deny or restrict that agency from groups of people? So framing is about how all those choices, both big and small, influence how people think, how they feel, and what they do. right? So kind of understanding emotions and decisions. And so I'm going to make that super concrete here for a second. I'm going to go a little bit outside of the confines of the project that I'm here to talk about. I'm going to talk to you about some work that we've been doing for a very long time in communicating the science of early childhood development, specifically the concept of child mental health, which for most Americans is either not true, right? There's, for a lot of people, the idea that young children can have meaningful states of mental health is invalid. And certainly it is an issue on which public will, public demand, public support for funding, for policies and programs that support child mental health is very low, is very reduced and restricted. So our charge here was to figure out how to frame, right? How to make better choices in presenting information on child mental health to increase people's support for a set of evidence-based policies, policies that come out of the developmental and intervention field that have been shown through solid research to improve children's mental health, to support positive development. Okay, and so this is how the experiment works. This is a large nationally representative experiment. It was conducted with over 6,000 people, but for the ease of simplicity, I'm just gonna say 6,000. And the way that this works is each of these 6,000 people get randomly assigned to read a message. And those messages are what you see along the horizontal axis, the bottom of the screen. So Brian logs on to the online experiment. He gets randomly assigned to read the message of collective progress and kind of social prosperity. So he would read about a child mental health program. It's about 80 words, but then this frame of collective progress and prosperity is at the top. So he would read something like, it's important that we do a better job of supporting children's mental health because, and we wouldn't say it in such a cliched way, children are our future, right? Their stable, positive, healthy development is vital to our ability to progress as a society and be prosperous. Elizabeth logs on. She gets randomly assigned. This is what random assignment looks like in experiments. That's why I'm doing this, to the message of vulnerability, right? So same program description, same 80 words, except the lead-in is different. The frame at the top is different. So instead of what Brian read, Elizabeth is going to read something that sounds like, it's important that we do a better job of supporting children's mental health because children are our most vulnerable citizens. They deserve our empathy and our compassion, and we must do better by them. Then I log on to the experiment and I get randomly assigned to the third condition, which is the treatment condition. So I read nothing. I'm this thin, depressing 0 line that you see across the middle of the screen. And then we all answer the same set of questions that are designed to measure how supportive we are of this set of evidence-based policies. So what you're gonna see on the next click are what I think are 2 gorgeous green bars are gonna appear on the screen. And what those bars are gonna show you is the extent to which hearing those different primes, those different frames at the top, affect people's support for policy. And I have no idea of the statistical acumen of this audience. So here's your quick stats lesson, everything you need to know. Up is good and down is not good, right? So you see 2 bars and you notice 2 things. First of all, that value that Brian received, the collective progress prosperity value, is making people to a statistically significant degree more supportive of those evidence-based policies. That's good news. We have a little framing dance that we do when we get those kind of results. Don't worry, Brian, I'm not going to do it here. But you probably also, let your eyes wander towards the right-hand side of the screen and see this less optimistic performance of the vulnerability value, which, just to be clear, is not only statistically indistinguishable from 0, which is no message, but is actually depressing to a statistically significant degree people's support for those policies. So just to translate that for you, if you're an expert or an advocate working on issues of child mental health and you use the value of vulnerability to frame those messages, you not only waste your breath, but you use your resources in a way that directly disadvantages the issues, the solutions for which you are advocating. And just to be clear, that's not what we want to do with our limited communications assets and resources. So the kicker is that in a subsequent piece of analysis, where we looked at all of the field's external facing materials over a 3-year period, so all of the press releases and websites and social and everything that they put out into the world, guess which value is used in over 90% of those materials, right? And so because of the format of this has to be a rhetorical question, right? It is the value of vulnerability. So in essence, what the field had been doing for a very long time with what in retrospect is a shocking amount of resources, is advancing a value that, again, not only wasted those resources, but worked directly against their goals as experts and advocates. So I want to make the point, kind of bring this back to our current context, to COVID, and the other events that have been kind of dominating our lives for the last 7 months. And just to make the case that framing has always been important, right? I've been doing this for 13 years and it has been important for every single day of those 13 years, but it is super duper important in the world in which we are living right now. And there's a variety, a potpourri of really interesting, or you might say depressing ways that issues are being framed that influence, again, how we think, how we feel and act. And so very early on in the pandemic, so I'm going to show you some of these frames, these unfortunate frames that I've collected over the last 7 months. And the first one comes from very early in the pandemic, where COVID was framed as the quote unquote Chinese virus. And what we see, what we know from a lot of research that's been done, is that that choice of information presentation is not inconsequential, right? It leads to some very specific ways that we think about this. It creates a fear of other. It creates a very strong kind of insular nationalism, and it creates a sense of thinking about other groups that wiggles and wanders and attaches to all kinds of in and out group ways that we think about our society. The next one is the now infamous, we've seen a kind of a slight resurgence in this one, I think, this idea of public health measures being recommended as characterized or as framed as draconian in their stance. And I think everyone on this call will understand the reaction here, but I just want to underscore its power, in which that kind of framing creates a clear sense that everything that's being recommended is an overreaction, makes people resistant to information, and highly hesitant to act on any recommendations or prescriptions that come from public health. Another one that's kind of more nuanced, but I think potentially more important than these top two, are the ways in which, and specifically related to older adults, the way that information or issues during COVID have been framed around protecting vulnerable populations. And we know from a lot of work that dates back well before COVID that this kind of framing has a real significant and measurable effect in instantly othering those groups that we have labeled as vulnerable, in creating a sense of zero-sum thinking in which any more for them means less for me, and creates this palpable sense of stigma that not only characterizes the way that mainstream culture thinks about groups, but also characterizes the way that affects the way that members of those groups think about themselves and create their identity in some really ugly and pernicious ways. Last but not least, the kind of health inequity messages that have been swirling around. Again, these are true. My analysis here is around the framing, not the validity of the data, but the way in which a lot of these arguments around people of color being infected, dying at higher rates are, without careful framing, tend to be perceived or explained through this idea of certain groups having deficient values, or making kind of poor lifestyle or health choices. Again, my use of air quotes there is designed to be plainly and overtly critical of that interpretation. And so all of this kind of boils down or comes together to this metaphor that I've come to use and think is helpful as a way of conceptualizing framing. So I think about framing, again, the choices that we make and how we present information, as this really powerful key that has the ability to unlock people's thinking, to open up new space, to open up new conversations, to allow people to engage with solutions and thinking about their importance in new ways. That's the positive side of the key metaphor. The negative side of the key metaphor, as you just saw, is that in turn, those choices that we make can have the opposite effect, right? They can powerfully shut down thinking, they can close off conversation, they can lead people to reject our messages and to go further and deeper into pre-existing dominant ways of understanding these issues. So all of this work on framing and opening thinking and shifting perspectives stems, unfortunately, from a problem that we all have. So this is a problem that I have. This is a problem that anybody who communicates about anything has, which is, just to be clear, everybody. And the problem looks something like this. It's a communications problem. Don't worry, we're not going to go any deeper or more psychoanalytical than that, is that I imagine a number of people on this webinar have been in this position before, where you think you have the perfect way of talking about public health, and you try it out with two of your closest colleagues who are also deep experts and practitioners in public health, and it is awesome, right? What could go wrong when it goes out to normal people, right? People who don't live and eat and sleep and breathe public health as you do. And you find that when it does, one of two things happen. So first of all, that message that was so powerful and resonant for you and your colleagues isn't for people who don't do your work, right? It doesn't have resonance, it doesn't have grip, it doesn't have traction, it doesn't cut through, whatever you want to say. It's kind of in one ear and out the other. The second thing that can happen, which is more unfortunate but still frequent, is that message which sends you and your colleagues running towards the importance of robustly funding public health services and research, sends the people you're communicating with in the exact opposite direction. And so I don't want you to take my word for this. I'm going to give you a quick example of what this looks like. We're going to go away from public health to give you some productive analytic distance, and then we'll bring it really close and we'll give you an example from public health. So the first example comes from, again, work that we've done on early childhood, where in the field, people who are developmental scientists and practitioners say things like this. They talk a lot about stress. This is a direct quote, that persistent stress can derail development and have negative long-term effects on health and well-being. So I said this was a direct quote. I've made one editorial change on this slide. In the original quote, negative was deleterious, but I've made that edit to be mildly less obvious and obnoxious than the point that I'm about to make. But for people who work in the field, this is like true, really true, truthity true, straight through true, lots of research, number of disciplines over a long period of time, which shows this to be the case. But unfortunately, for people who are not in the field, people who are not trained or practiced developmentalists, this kind of message elicits things that look and sound like this.
Life's hard. It's supposed to be hard. You know, what doesn't kill you makes you stronger. You know, all the bad cliches you can think of. I mean, there's been people that have come from absolutely nothing to make it in whatever society's eyes deems success.
So I hope you could all hear that. I realize it's a little hard to hear. The audio is kind of bad over the street noise in Tucson, Arizona, which is where this gentleman is being interviewed. But just to be crystal clear, that which you just heard, what doesn't kill you makes you stronger, is not what this expert intended when he or she opened his or her mouth to deliver this message. So there's something going on between the intention, the delivery of the message, and its actual effect, its reception, right? And I'm going to leave you on the edge of your seats wondering what that is for one more second as we go closer to home and show you what this looks like in the work that we've done on public health. So people who work in public health say things like this: public health engages a network of professionals that uses evidence to promote living and working conditions in which all communities have the opportunity to be healthy, right? This sounds like something that I imagine some of you maybe have said. This might be a direct quote from somebody who might be on this call. I have no idea. But for people who work in those other sectors, education or housing or business or even healthcare, the way that this message gets processed, the effect that this message has, is something that looks and sounds like this.
If I were to ask you what is public health, how do you think you would answer that question?
It's not an easy question to answer.
A lot of doctors have masters in public health, but I'm not sure what it entails.
If you work in the public health profession, aren't you concerned with policy or something?
When I think of public health, the first thing that comes to mind is health care for the poor.
Dealing with the health care needs of the indigent.
Certain facilities that are operated and funded by the government.
When I think of public health, I think about the CDC.
I think, first of all, the CDC and then the local Department of Health.
I think of the CDC. They kind of inform the masses.
Educated people about the different viruses and things they can catch if they don't protect themselves.
Identifying patterns so that certain things don't happen, outbreaks.
Like infectious diseases, and if the produce is tainted, then, you know, the public needs to be informed.
So that one I think is a little less dramatic, hopefully, than the one about what doesn't kill you makes you stronger. But it is clear, and I just want to make this clear in case anyone had difficulties hearing the audio, that what you heard on the right-hand side of the screen, while it may not be incorrect, is certainly incredibly partial in its understanding. It does not encompass the breadth of understanding that this expert intended when he or she is communicating this message on the left-hand side of the screen. So what is it that explains these differences, this gulf between the things that we say and the effect that our messages have? And it is this little thing called culture, right? And I don't mean culture in the kind of Indiana Jones external artifact kind of culture, but rather culture in mind. Culture as a shared set of patterns of reasoning, of understandings, of assumptions, of propositions, of ways that we understand the world and that we use to make sense of the information that we are presented with. And so a good amount of the work that we've done with Brian and colleagues at Beaumont and Aspen was digging into this deceptively simple green bubble of culture and figuring out what are the pre-existing understandings, the deep kind of cultural models that inform people's thinking about public health. And that information, I'm gonna not go through that here, but is available in reports that exist on the Beaumont website as well as on the Frameworks website. But the interesting thing or the important thing about understanding culture is that when we understand culture, we get an incredibly crisp view of the framing challenges that exist on an issue. So understanding what's in that green bubble of culture when it comes to public health and how people in those sectors think about it sent us clearly towards a set of 4 challenges that exist on the issue. I'm not gonna go through these in any great detail. I'm gonna take one of them and I'm going to use it as an example to talk about how a challenge can be addressed through the use of frames. And the one that I'm going to take here is the third one here. But I want to first make the point that, again, there are materials available where we have addressed each of these 4 challenges through a number of framing strategies that, that can effectively be leveraged to bridge that gulf between the things that you say and the way that they are heard, processed, and understood and used by the folks you are communicating with. But again, we're just going to take the third one here, which is the challenge. And I think this is true. So this is kind of set up in Brian's introduction. It's also evidenced to a degree by the findings that Elizabeth presented, is that there is a challenge around kind of the thinness of people's understanding of public health, what it does, what it brings, what it offers. And so this challenge is really the need to deepen people's senses of the field, what it is, what it does, what it brings, kind of skills and expertise. And on this particular challenge, we deployed a set of framing strategies. The one that emerged as most effective in our research was metaphor, right? And metaphor is an incredibly powerful framing device. And what metaphors do is that they help do that deepening, right? They have this incredibly fast, efficient way of expanding our thinking, of creating new ways for us to see issues, engage with them, talk about them, and see the importance of solutions. And a great example of that is, again, pulling from our work on early childhood as an example, the work that we've done in the field over the last almost 20 years now, in which you take something very familiar, the process of building a structure, a house, a building, and you compare it to something highly unfamiliar through the metaphor, which people may have heard about, called brain architecture, right? So this is what we call an explanatory metaphor. It allows people to think about the thing that is unfamiliar by recruiting some of their understandings of what is familiar. And what happens when this metaphor is cued again and again and again is that it starts to get people thinking about brain development in some different ways. So if brains are built like a house, then there's a set of things that I can understand and that kind of fall into place in my thinking. Well, first of all, it means that what happens early really matters. It means that those materials and ingredients that are used in development are not inconsequential early, but they are of foundational importance. The timing matters, the activeness of the process is significant, and most importantly, that what happens early when we are laying the foundation and completing some of those early operations affects everything that gets built on top and that happens later. And so what happens when these propositions start falling in place, and as we've seen over the last 20 years, is that the policy discussion shifts foundationally, right? And it begins to focus on solutions that with previous understandings did not make sense that now suddenly do. So to address this third challenge, again, deepening people's sense of the value of public health, the expertise and the skills that the public health field brings to problems, we tested a number of different metaphors. The one that emerged as most effective across that testing was the idea of navigation or a GPS system. So the metaphor kind of, you can see it on your screen on the left-hand side of the screen. It's kind of talks about the power of GPS and helping us navigate complex terrain, and kind of takes that and connects it squarely to what public health professionals do, explains that they draw on data to chart a route. You can see the metaphor there as well, of where we are to where we want to be, and the importance of using data to help us all move towards solutions. And I would argue that this metaphor, if anything, has become monumentally more important to use in the current context, as Brian said at the beginning. So in our testing, what we found is this metaphor consistently builds awareness. It shifts people's thinking about the value and breadth of public health. It fosters understanding of the problem-solving nature of it, and it creates a really palpable, vivid illustration of the way that public health data and professionals and skills can be kind of harnessed towards moving in better directions. The importance here, I think, and these are some of my last points, is that these framing strategies, this metaphor and the other strategies that I threw up on the right-hand side of the screen, are really only effective if we can use them all together. And so this is, I'm not going to characterize the field of public health in this way, but this is certainly the way that most of the fields in which frameworks works tend to look, right? And so they look like this. I'll take education for an example, right? You've got the people who are doing higher education, K through 12, pre-K, educational disparities, school discipline. They're all talking in a million different ways. And what do you think this does in terms of changing people's thinking, of shifting what is in that deceptively simple green bubble of culture? The answer is it does not do a lot. And so the move that we have to make is towards something that looks less like what we see on the left-hand side of the screen and more like what we see on the right-hand side of the screen. And I think I'm gonna stop there. I'm gonna hand things back to Brian if I can figure out how to do that. Here we go. I think they're back to you, Brian. There you go.
Thank you, Nat, and thank you, Elizabeth. So I think we've learned, a couple things. What I take away from this is, as much as we might believe that there is a political party for public health and there's a political party not for public health, that may be less true than we believe. And so I think this is a critical time as we enter an election cycle, that this should be, a public health election. We should be asking candidates, what are your plans to rebuild the public health infrastructure in this nation? I am a big fan of metaphor. And what I have kept saying to people through media interviews is, you would never put someone on a battlefield without the tools to win the battle. That's what we've done to public health by chronically underfunding them. When the battle finally came to us, we were not ready. And every time I use that, the reporters will say like, oh, I get that now. But I think Nat is really right. We have to kind of agree and use some of our metaphors consistently. Much of what Nat is talking about is available at the website phrases.org. That is an entire toolkit on how to message public health, and one that we hope will be helpful, not specifically for COVID, but more generally public health. And the one that I like the GPS one, but my favorite is actually that public health is like the foundation of your house. That if that is not safe and secure, nothing else really works. And I think in COVID, we are seeing that how many things in the history of our country have led us to lose more than 200,000 Americans and bring our economy to a screeching halt. And so we have a choice to make about whether we're going to just continue to, paint the walls and put up the wallpaper, or are we actually going to fix the foundation? So I hope that you all have found, this information useful. It was really intriguing. we have a lot of questions that I'm going to try to get us through. So for the survey methods geeks out there, Elizabeth, can you talk a little bit about the sample, the geographic area, the representativeness, the nuts and bolts of the survey for the geek crowd?
Sure. So we conducted a national telephone survey, so both landline and cell phone only respondents. So it was conducted over the phone. It's a nationally representative sample of 800 registered voters. We set quotas based on registered voter populations within states and nationally. So it was a national sample of registered voters. So that means regionally, by gender, by ethnicity, matches registered voter population statistics.
A good question from Peter Mineta. How can these encouraging poll results help counter the very vocal anti-public health minority who also have significant power over policy change? To the panelists, how would you respond to that?
I can take a first shot, Elizabeth, even though it's probably your question, but I've got an immediate thought. It's probably not a good one, and then you can give the good one after it. But so there's an area of social science. It's primarily social psychology research, which is research around the effect of norming, right? And so that is the way in which our behavior is highly determined, is highly shaped by what we perceive other people are doing or other people are thinking. And there's fantastic experimental evidence that shows that if you can manipulate people's sense of what's normal, you can directly affect behavior, you can channel thinking in particular directions, you can open people up to all kinds of stuff. So this is certainly not the only value of the data that Elizabeth has presented, but I think it is one, right? And so one way of using these data is to continually point to the wide and broad support that public health is experiencing, although differential in the ways that Elizabeth is talking about, across the population, right? And so there are ways of not taking on that vocal kind of minority of voices that are speaking out against public health, but really instead kind of homing in on the degree to which there is widespread support for this field and the importance of its work now and going forward. And I think there's subtle and not so subtle ways that you can really kind of activate that norming principle using these data to kind of move people and pull people along.
I completely agree with Nat. In terms of, we saw in the slides that there was support across partisanship, across a lot of demographic groups in terms of the value that public health departments have in communities and making healthy communities. I understand you have the minority who, might have negative perceptions or be anti-public health, but I think we're living, this entire year has shown the importance that public health has and public health departments have. And I think that there is a way to not capitalize, but I think that there is a way to show how important public health departments are in these specific instances in health crises and why they're so important. And I think what you take from what Nat presented in terms of some of the challenges of people not really understanding what public health is, that this can really show, we're in an episodic, we're experiencing it in terms of how important public health departments are and the services that you offer at one level. And I think that there's, support across partisanship and using the results to show that there's support across partisanship and all demographic groups in terms of the value that public health departments provide is part of achieving that.
Thank you. Those are great answers. This is another question for Elizabeth. Were there any differences within subgroups in terms of the willingness to pay for more taxes?
Yes. and some of that data I know is public, but I can give you some of the audiences that were more supportive of paying more in taxes. You have voters who are older, women, whites. They're more likely to say they would pay more in taxes than they were in 2018. So their support levels actually increased. When we're looking at just differences in the 2020 data, you have women are more supportive of paying higher taxes. Younger people are more supportive of paying higher taxes, minorities. And then, of course, there were sharp differences across partisanship, which is not surprising in terms of Republicans being less likely to want to pay more in taxes in support of public health.
So for Nat, I'm going to throw you a softball question, Nat. Given the recent resurgent kind of new interest in understanding how structural racism impacts health outcomes, and given the potential sensitivity of these kinds of messages, what recommendations do you have for framing messages that we want to share about the connections between racism, inequity, and health? That's an easy one, right?
Yeah, I know your default sarcasm. So whenever you say softball, I know it's going to be anything. But I was just trying to. I think that question came from someone named Jamila, and I was just trying to send some messages back to the group, and then someone from the support is saying that they're not making their way back to the group. So I've got. I'll talk a little bit about that really quick, and then I've got two pieces that I've recently written that fairly directly speak to that question. So if there's a way, if someone has received the messages that I've just sent and can send them to the whole group, that would be great. If not, Jamila, I can get your information afterwards and I'll make sure I'll send you them. So this may be a slight tangent, but hopefully I'll get back. So I have been frameworks and I have been doing research on how to get people to understand what we used to call structural racism, what now is being called systemic racism, for like 20 years. And it has been decidedly difficult to get people to shift from what are largely kind of personal understandings of racism, that racism is really about, that hateful, crooked cop or this corrupt, backwards judge, towards an understanding in which people can see that systems are involved in kind of the history, the current, and the perpetuation of differential outcomes between groups of people. I think that those words are being used dramatically more frequently than they have, as in the 20 years that I've been studying this over the last 7 months. And I think that's a good thing. You have a lot of discussions about structural or systemic racism in a way that you did not before. A lot of that is around issues of health inequities and disparities. But I also think that just saying those words is not enough, right? And so what we have to do is to help people, and I don't mean that in the patronizing way that it may sound, is that our role is to help people understand what structural or systemic racism really means, and to get smarter about how that issue works, to an extent to which people can start to see and support the solutions that are necessary to address it, to get away from, punish that one cop, to thinking about the system of policing, the system by which police officers are recruited and trained and incentivized and all of these things. And so the pieces that I've just sent out are kind of dig into some of those recommendations in greater detail, but I think there is a tremendous opportunity right now to do that explanation. That's a positive way of saying it. Another way of saying that is that it's probably an opportunity that's not gonna be there forever or come around again, and that the way that we communicate about structural and systemic racism right now is paramount, is so important, and we've got to get it right. So
now I know how the debate moderators felt. There's a lot more to cover and very little time. The chat has amazing questions, and while I believe we are at time. Am I correct? Just looking for the admin. Are we at time, admin? Oh no, we have more time.
We have a lot more time. We got
We
until
have a
3.
lot more time. I'm
Let's
sorry.
do it.
This is what happens when you misread your calendar. So we can ask many, many more questions. This is great. Have the panelists explored the relationship of faith group commitments to COVID-related attitude, beliefs, and behaviors? Nat, any work with faith-based groups?
So none from me, but I wonder if in the work that Elizabeth has done more generally or outside of this project, there's any interesting trends or findings.
Not that's recent, that would be applicable given, the area that we're in. So unfortunately, no, I don't have a response to that.
So I'll say one thing, Brian, just because we got to have a response to everything, right? And if Elizabeth and I don't have one, we'll figure one out. So we do have some research that's in the field, that's been in the field since April, which is a year-long, both qualitative and quantitative tracker of some foundational core American cultural models and how they are changing and shifting over time in response to events. And it's a panel design. It's a large panel. And so there may be the opportunity to cut that sample and look at faith-based groups. I'm not sure if that part of the sample, if cut, is big enough to do that kind of analysis, but I will go to my data geeks later today and ask them that. And if it is people who are interested, we have a monthly newsletter that comes out that reports findings from that work. And if you're interested in following that, I can't promise that there'll be something about faith groups, but if there is, we can try to fold that into a subsequent newsletter.
So I want to respond to some of the questions that are in the chat here. Jessica Collins asked if there could be some engagement for work that she's doing in Massachusetts. Jessica, email me, castrucci@debeaumont.org. We'll work with you to figure it out. Nancy Goff said, this is good work. However, it's like most public health led messages over the past few decades, it's very public health centric. Traditional business or salespeople have been known for a long time that if we want to engage people and inspire action, we need to meet them where they are. This is where I would point you to the phrases toolkit. I mean, I think a lot of what we talk about is the what's in it for me. And so the foundational metaphor is there to suggest that if you want to achieve something in a community, whether you want more people to come to church, whether you want to get people to have better test scores or a lower rate of dropout, or if you want better productivity in your employees, all of that is kind of founded on health. And so it is, I think, about reframing and having a conversation, not walking into the superintendent's office of a school and saying, let me tell you about my smoking program. Let me tell you about our STD program. It's about saying, let us help you in health achieve the things that you want to achieve. We can help you make sure that the kids are reading on 3rd grade level. We know that health has a significant role to play there. Let us work with you on high school dropouts. Let us work with you on graduation rates, on test scores, because if kids are healthy and they come to school healthy, they're going to have better outcomes. That's reframing it to the needs of the superintendent, to the needs of your partner across the table, instead of us always showing up with kind of our book smarts. And that was one of the moments in one of the conversations around phrases. Nat said, several of the focus group respondents said that public health is book smart, but they didn't mean that as a compliment. Nat, anything else you'd add on this idea of how to meet your partner where they are?
So I think you said this was Nancy Goff's comment. And so I like the first part of that where she said this was great. And maybe we should just focus on that for a second. So I think there's a difference between meeting people where they are and appealing to what they value, right? Meeting people where they are and kind of engaging with their current understandings is a strategy that a lot of work has found to be unsuccessful, because when you meet people where they are and engage their current understandings, it's very difficult after you've reminded them of what they already know to get them to kind of shift to a new perspective. So what I would say is that Brian's right on. So a lot of this work, and I think this is not surprising, a lot of this work shows the power of public health professionals activating or showing what public health has to offer, the things that people in those sectors actually care about. So it's not about talking about the value of public health, right? And I think that that's what most public health communicators do, but it's in talking about what public health has to offer to the things that folks in those sectors care about. And again, I think that's kind of commonsensical, but when you look at the way that this issue is communicated, it is rarely framed in those ways. And I think that's a really powerful part of the research. And there's a lot in the toolkit, as Brian said, there's a lot of detail and kind of what that looks like for each of the sectors that we did research with. And again, I would just encourage people to spend some time with that resource and get more concrete specifics than I've said in my answer there.
So Hannah Kinzer asks a really great question for early professionals. I want to encourage folks to follow the Beaumont Foundation, both our email list, our Twitter account. We will be releasing next month our call for our next cohort of 40 under 40 in public health. Jamila Porter, who asked that really wonderful question. She was a previous awardee. So we'd love for you to know that that's happening. And so her question was, how can young professionals entering the field of public health who may not yet be experts leverage their unique position to change the rhetoric used in public health discussions? Nat, I'll push that to you.
I don't know. I may push that back to you, Brian.
All right.
I actually feel like you're in a better, since that's such a softball, I feel like you may be in a better position to talk about that. I feel like that's a kind of a question that's better for someone who kind of has their hands around on the field. I don't know.
And I encourage folks in the chat to provide answers who are also some of the gray hairs in public health. I've gotten more right around here since COVID started. I think the thing that young folk, early career professionals can do is just continue to talk and engage and leverage the different platforms. And if you're in a health department, push for the use of Instagram and Twitter. I mean, Med Twitter is so strong because there are so many physicians on Twitter, and public health Twitter isn't as strong because we're not all there and folks aren't talking. This is a place that I think young professionals who are much more native to digital communication can be a huge support for those who don't see that role in some of the work. So you may hit a couple roadblocks along the way, but I really think to stick at it and engage with folks, on social media, find folks to talk to who have been in public health for a long time and share your ideas. I think it's really important. Patrick O'Carroll asks, can panelists speak to a longer term strategy to help Americans better resist the lure of lunatic assertions, Patrick's words, and conspiracy theories? I think Voltaire was right when he said, those who can make you believe absurdities can make you commit atrocities. Yet there seems to be about 40% of Americans not just amenable, but eager to embrace certain absurdities rather than adjust their tribal affiliations. Now, I would say that, again, 7 out of 10 folks that answered our poll said that local health departments were important. So the question is, how prevalent are those who hold those absurdities? But panelists, what are your thoughts?
Elizabeth, I've been talking a lot. You want to take this one?
Well, I mean, I think it goes to, this is a similar answer in response to the other question, which is, yes, there are fanatics out there, but I think, the way to address it is you have the data, you have the messaging that Nat's put together in terms of the toolkit, in terms of how to talk about this. There is going to be a percentage of the population that you're never going to get on any specific issue. And that's on either side of the aisle. So I think, you just have to have the understanding that, the research that you've done and the tools that you're using and the way that you're framing and talking about things is how to push back on it rather than focusing on, you know, the negative.
There are a fair number of COVID-specific questions that are coming up in the chat. And I want to redirect some of those to a new initiative called the Public Health Communication Collaborative, PHCC. PHCC was put together by the CDC Foundation, Trust for America's Health, and the Beaumont Foundation to provide some of that immediate need around messaging. We are holding monthly calls to really understand these questions, and we'll be coming out with more toolkits to help answer some of the messaging questions. And there's also an existing document on the PHCC website, which the support folk can put in the chat, that will really help people, I think, with some of those more immediate needs. I think another kind of theme here in the chat is the need for partnerships. We have many questions, you know, how do we do this now? How do we do this in the middle of COVID? I think that was part of our challenge, is that being ready for something like COVID is building partnerships before COVID happens. And that's where we can use the Phrases Toolkit to build better partnerships. Nat, I wonder if you might comment on how you see the Phrases Toolkit helping local health officials and state health officials and everyone working in public health build some of those critical partnerships so that we're ready to engage them when we have a need to, when there is a crisis.
Yeah, I think you kind of paraphrased my answer, so I'll say it again with some different words and from a different person. But I think a lot of it is in recalibrating the way that we think about partnerships, right? So the time to make partnerships is not when you need them. The time to make partnerships it's kind of like a preventative perspective on relationships and partnerships, right? They need to be in place such that when whatever happens, they're there and they're strong and they're robust. And so you said that, Brian. Another way of thinking about partnerships and kind of communications more generally is that last slide that I had about the arrows. Like, the field is not going to make the partnerships it needs based on, no offense, Brian using the frames all over the place, right? That's not the way it's going to happen. It needs to be a concerted, collaborative, coordinated effort to start to talk about public health in the terms that other fields can hear and can see the value of the work. And so the ideal, and this is kind of dreamy, I know, but is that a whole bunch of people across the sector start framing and communicating about public health in different ways. And that's the way the stuff kind of bubbles up or amplifies its effect in starting to shift the way that not particular education people or business leaders or housing people think about public health, but the kind of discourse in those fields about what public health is and has to offer.
Matt, let me ask you, when the pandemic started, many public health people started talking about lockdown, shutdown, stay-at-home orders. How do you think that has influenced how the pandemic has rolled out, instead of us framing or messaging around, we want to open sooner, safer? Do you think that had an impact?
Yes. I mean, I think you think it had an impact, right? And I think whoever asked that question, if it wasn't you, thinks it had an impact. And so it's just so easy, and I think obnoxious and unproductive to kind of, what is it, Monday morning quarterback? Is that the sports metaphor? These things that we did, like, but at the same time, those messaging mistakes speak to the importance of having solid framing approaches and recommendations that we use in times of pressure, because just like anything else, the more that you're used to using those, the less hard and more instinctual it is. So I think generally, and I think some of this is in the toolkit, is that these public health messages that focus overwhelmingly on the problem right in front of us and less aspirationally on the changed outcome that public health work creates, which is just what you did, Brian, in your reframing. Those more aspirational kind of, if we did this, we'd be here kinds of messages, I would say across social issues, there's really solid evidence that suggests that those kind of messages are more effective, right? Are more engaging, get people to participate, kind of don't cause people to shut down.
Elizabeth, when you look at the data that you have for this general support of public health, in your brain, just as a scientist, as a pollster, how do you kind of, justify those data versus what we're hearing on our local news?
So, I mean, I just want to agree with Nat in terms of the framing, because as you saw, as the crisis kind of, as the pandemic kind of moved, messaging started shifting. So instead of stay at home, it was safer at home. So, I mean, just that little tweak in terms of how you message or frame something can have a lot of impact on attitudes, acceptance, and perception. And then Brian, in terms of your question, I think that's why you need to do things like the Beaumont Foundation has been doing in terms of putting out these toolkits, conducting research, showing that there's broad support, showing how people are feeling during this time. And I think that's the way that you can counteract misconceptions and misperception.
Thank you. From our friend and colleague, Lloyd Michener down at Duke, COVID is refocusing public health and serving as a reminder of the need to partner with local groups and organizations. What frames and messaging will help public health adapt, and what frames and messaging will help those groups be more receptive?
So because you said the word frame, I guess that one's got to be me, right?
Got to be.
So I don't know if I can answer that question as explicitly or specifically as I would like. So I'll use my prerogative as being a panelist to answer it in the way that I want to, which is the power of examples and exemplars in shifting people's thinking. So there is a way, and I hate these words kind of like opportunity or silver lining, but what we are in and what we have been in for 7 months is a fantastic example of what Lloyd just said. It's a fantastic example of the importance of a robust, preventative, prepared, collaborative field of public health, right? It has a negative case. When we don't have it, here's what happens. And hopefully at some point it will have a positive case in which we can see what happens when it is the way that it should be. And so I think, and I think this is a safe prediction, that the field of public health should and will be talking about COVID as an example that illustrates the importance of their work and the ability to collaborate with other sectors for a very long time. And I would suggest that we think very hard about how most appropriately, but in a disciplined way, to make full use of this example to shore up the kind of support that public health needs to deliver on its value and promise.
I want to address some of the comments that I've been seeing in the chat about how public health talks about itself, that we need to stop reinforcing the idea that we are undervalued, or as Sarah Archer put it, we need to stop crying we're too poor and focus on the kinds of services that people know about and value. And I do think there is something to be said for how we talk about public health and how we come from a position of strength. And I think there are data now that very much support that people do fully understand that local health departments and state health departments are critical for community health. I mean, my favorite data point from Elizabeth's presentation was the change among strong Republicans going from 38% to 61%. This should give every single Republican running right now full license to talk broadly and full-throatedly about public health. And we have to do the same, that even though we maybe do not have the funding that we need, we are throwing everything we have at the response, and that public health is there to protect Americans. And I do think this is the time to double down on the fact that we spend $700 billion every year on defense, and no foreign power has ever taken 200,000 American lives on American soil. And so we're just trying to get 4.5 billion. So that should be an easy lift against what we spend on defense, and just drawing some of those just realities. This is a moment for public health to redefine its value and try to ensure continued funding for decades to come. I want to ask, I'm looking for the question. So I'm going to throw this question at Nat again. Nat, when you look at some of how what Patrick called absurdities are out there, and they're shaping the conversation, do you think they're just better at framing than we are?
So I think that may be true. The other heuristic, or the other way of looking at that, is they've got an easier task, right? It's much easier to make people confused and doubtful and distracted than it is to make people smarter, more engaged, and more supportive of specific solutions, right? And so I think that's probably both better framing, but not an even or level playing field. And so when Patrick asked his question before, the things that I would think about are, when you engage in that discourse, avoid anything that allows people to polarize, right? Avoid all cues that allow people to splinter into this camp and that camp. Don't take the bait, right? This is something that people do all the time, is that you end up repeating the fallacy that you are trying to correct. And in so doing, giving it more air, giving it more breath, giving it more exercise. Because the best predictor of what people believe is how many times they've heard it. So think about that in the way that you're engaging in those conversations, and instead try to appeal to things that are common, in the way that Elizabeth talked about, these kind of common understandings. Don't reference the fact that they're common across political ideology, because that's a splinter cue, but there are things, and public health is lucky in the fact that it is one across which there are some common beliefs and commitments to importance. And then I think there's a set of longer term things, like 50-year long-term things that we need to be working on, in terms of people's understanding of democracy and some of its core components. People's understanding, this is one that's really important to me, people's understanding of science and the way that we message about science has denigrated and eroded in some really problematic ways. So I'll leave you on that optimistic note. But I think Patrick's questions are fantastic, and they're not ones that I think any one of us on this panel can kind of conclusively answer. They're really hard. That's the hard question, Patrick.
So going back to the GPS metaphor, how can we use that metaphor to make a case for looking at certain issues that are not always seen through a public health lens as public health issues?
Do you have a thought on that one, Brian?
It's a tough question. So
it is a hard question.
Lauren Tobias asked this question, and I think the heart of the question is, how are we reframing, using that GPS metaphor, how do we reframe something like food insecurity as a public health issue versus not a public health issue? And Lauren, if you're still out there and you have clarifying comments, you are welcome to use the chat.
So I'll, if Lauren is there, I'd love to hear more. But I mean, the way that I would think about it is fighting the tendency to lead and go strong from the beginning with public health, right? When you hear about food insecurity, I think a lot of us would want to say, hey, that's a public health problem, we can help. Instead, I think what you want to do is kind of lay out, explain the problem, talk about some of its causes and some of its causes, and kind of back your way into the idea that public health plays a role in addressing some of those causal elements, some of those problems. And then I think the really important thing is to do that with explicit, concrete, specific examples of public health work that addresses those kind of causal elements and leads to better outcomes on the problems that you've set. So I think we need to avoid right off kind of being, singing the public health song, and instead take some time to kind of unpack what is causing the issue and then showing how public health is part of remediating or addressing those factors.
Thank you. So I want to just put in, again, seeing a fair number of questions about vaccine messaging. I'm going to push those questions back to that public health communications collaborative. That's where we're trying to take on some of those very immediate questions. Nat is talking about research here that we did over a 2-year period, and was more focused on selling public health, getting people to understand public health. I think these very specific COVID questions can be handled by the Public Health Communications Collaborative, and we really welcome your engagement. For either one of you, when you think about messaging, we're now, what, 9 months into a pandemic. How do some of these framings, how do some of the frames, how does some of the messaging change as fatigue increases?
So, I mean, I outside of health, a lot of my clients have asked that in terms of how to communicate within the COVID environment and how to deal with COVID fatigue. I still just would point to the fact that for most Americans, the coronavirus is still the #1 issue. It's the most pressing problem that they want addressed. And although you may believe that there's fatigue related to it, it's still not showing up in the data. They still don't think it's resolved. We're still in this crisis. We still don't know when it's going to end. And so I understand that within the policy circles and in public health, it may seem that like you might be talking to a brick wall, and then there might be fatigue, but for the American public, that fatigue doesn't exist yet. But I can turn it over to Nat because I think he wanted to say something as well.
No, I think you are absolutely right. So there's an impatience for people with their communications. I've said this 5 times, I can't say it again, but there's good research and common sense that says that at the point at which you are utterly sick of saying it, it's only then just barely starting to have an effect or an impact on those you're communicating with. And I think a lot of times there's an underemphasis or a lack of realization of the discipline and the repetition and the commitment to messaging that is required to have an actual effect. So whether you're sick of saying it or not kind of doesn't matter, because I think Elizabeth is right. Like, people aren't sick of hearing it. They probably don't even register that they've heard it yet. So it's not about you, it's about them, is kind of what I would say, right? So as soon as you're sick of it, that means it's maybe almost just starting to find its way out into the world and have some effects.
So I want to thank the panelists. This is my Jerry Springer style final thoughts on today's webinar. I hope that you can take something away from today. I really don't believe webinars are meant to be entertaining. I think they're meant to give you resources and access to tools. And that is at the heart of de Beaumont. Pete de Beaumont made hard to find tools. And the foundation that is named for him, we are here to create practical tools for the public health workforce to advance the goal of every community getting the opportunity to achieve their optimal health. Check out the blog on polarization. Please sign up for The Beaumont's information, the Beaumont's newsletters, that's where we push out a lot of this stuff. We're always on Twitter at all hours of the day. Keep sending questions to us. We will try to get answers as best we can. The beauty of this 300 some odd person webinar is it hopefully demonstrates that through all the harassment and some of the negative connotations that come to the work that we do in public health, getting yelled at when you ask someone to wear a mask, we have a strong community and we are in this together and we are here to help each other. So stay strong, stay connected, and stay engaged, and keep reaching out to us because we are here to help. So with that, thank you everyone for attending today's webinar. Nat, Elizabeth, thank you. Thank you for the support team. We will talk to you again soon.
Thank you all. Thank you, Brian. Over and out.